3:47 a.m. The hospital alarm sounds. The third patient is dying, and nobody knows why. Dr. Williams panics. Call the CDC. This could be an outbreak. Meanwhile, Margaret, quietly observing, sniffles and murmurs. If only they had listened. By morning, everyone would learn who Margaret really was.
Margaret Chen, 68 years old, has been walking the corridors of Metropolitan Hospital for 50 years. But her story began long before these sterile halls became her second home. Born in San Francisco to Chinese immigrants, Margaret had always felt the call to serve others. At 18, she enlisted in the Army as a medical corpsman during the Vietnam War. 3 tours of duty in field hospitals, treating wounded soldiers under impossible conditions, had taught her to recognize death by its smell, to diagnose by touch when equipment failed, and to make life or death decisions when no doctor was available. After the war, Margaret returned to civilian life and nursing school, but the military discipline never left her. She approached every patient, every symptom, every crisis with the methodical precision of someone who had learned medicine in a war zone where mistakes meant death. For 30 years, she worked as a registered nurse at Metropolitan Hospital, earning the respect of doctors and patients alike. Her colleagues called her the detective because she could spot illnesses that others missed. But life has a way of humbling even the most dedicated. When her husband died in 2010, the medical bills drained their savings. Margaret's pension wasn't enough to cover her modest expenses, so when she reached retirement age, she quietly transitioned to part-time work in the hospital's housekeeping department. The young staff saw only an elderly cleaning lady, unaware that beneath the janitorial uniform was someone who had probably seen more medical cases than most of them ever would. That night, when the third patient arrived at the emergency room, Margaret immediately noticed. She was mopping the floor near the trauma bay when the ambulance brought in a 45-year-old construction worker. Same symptoms she'd seen twice before that week: high fever, shortness of breath, rapid pulse. But most importantly, that smell. Very faint, almost imperceptible. It wasn't the typical hospital odors of disinfectant or medication. This was something else, something that took her back to 1985, to a case that had haunted her for decades. Dr. Sarah Williams, 32 years old, Harvard Medical School graduate, infectious disease specialist, was one of the brightest doctors in the hospital. She had published papers on emerging diseases, lectured at medical conferences, and was considered the hospital's go-to expert for unusual cases. But that night, the situation she faced tested all her knowledge. Standing in the emergency bay, her confident demeanor was beginning to crack. "Complete blood count normal, blood cultures negative, chest x-rays clear," said Dr. Williams, shuffling through the files in her hands with increasing frustration. How is this possible? Patients are dying, but no tests are abnormal. The symptoms present like severe pneumonia, but every diagnostic tool we have says otherwise. Margaret was quietly cleaning in the corridor, moving slowly to avoid drawing attention, but she heard every word. Her trained ear caught the subtle details that others missed. She remembered encountering a similar case in 1985, when Dr. Morrison was chief of staff. He had been old school, the kind of doctor who still believed in listening to nurses who had been around long enough to see patterns that textbooks couldn't teach. But Dr. Morrison had retired a decade ago, and the new generation of physicians relied heavily on technology and protocol. The first patient had been a 28-year-old nurse from the pediatric ward. Margaret had been working the night shift when she was brought in. The second was a 55-year-old administrative assistant from the billing department. Now this construction worker. All three had something in common, but Margaret couldn't quite put her finger on it yet. Dr. Williams called an emergency meeting. Word spread quickly through the hospital that something serious was happening. Hospital director, Dr. Anderson, a man in his early 50s who had run the hospital with corporate efficiency for the past 8 years, arrived looking concerned. The infection control team, led by Dr. Patricia Hughes, brought their laptops and protocols. Laboratory specialists, including the chief pathologist, Dr. Michael Rodriguez, gathered around the conference table. 12 specialist doctors sat around the polished oak table in the hospital's main conference room. The room itself spoke of institutional authority, dark wood paneling, diplomas and certificates covering the walls, a large monitor displaying the hospital's mission statement. The air conditioning hummed softly, and the fluorescent lights cast everything in a clinical white glow. 3 patients, similar symptoms, but no tests are explanatory, said Dr. Williams, her voice tighter than usual. We may need to contact the CDC. This could be a new viral infection, possibly related to the recent construction work in the building, or worse, a bioweapon. Dr. Hughes, a methodical woman who had built her reputation on following proper protocols, pulled up her checklist on her tablet. We've run the standard infectious disease panel. Negative for influenza, COVID variants, pneumonia, bacterial infections, even exotic diseases like tularemia and anthrax. Blood work shows elevated white cell count, but nothing specific. Could it be a bioterror attack? Asked the security director, a former police officer named Captain Stevens, who had been hired after 9/11 to oversee hospital security. Every possibility is on the table, said Dr. Anderson, his executive training showing in his measured tone. I'm considering quarantining the hospital. We could be looking at the early stages of a pandemic. The last thing we want is for this to spread beyond our walls. Margaret heard what they were discussing from the corridor, where she was carefully dusting the same picture frame for the 3rd time. She couldn't stand it anymore. Every instinct she had developed over 5 decades was screaming that they were looking in the wrong direction. She knocked on the conference room door. Yes? Said Dr. Anderson with an irritated voice. Important meetings weren't to be interrupted by housekeeping staff. Margaret entered slowly. Everyone in the room looked at her. An elderly Chinese woman wearing a faded blue cleaning uniform, her gray hair pulled back in a simple ponytail, carrying a spray bottle and cloth. To them, she was invisible labor, part of the hospital's background. I'm sorry, doctors, but I want to say something. Dr. Williams frowned, checking her watch. We're in a very important meeting right now. Can this wait? We'll talk later. But doctor, I've seen this disease before. Uncomfortable smiles around the room. Dr. Jeremy Walsh, a 29-year-old resident who had graduated top of his class, whispered to his colleague, the old lady has become an internet doctor. Margaret continued, her voice steady despite the dismissive atmosphere. In 1985, exactly the same symptoms. The chief of staff at the time, Dr. Morrison, had listened to me and, thank you, said Dr. Anderson in a sharp voice, his executive patience wearing thin. But we have specialists for this matter, people with medical degrees and years of training. Could you please leave? We need to focus on real solutions." Margaret nodded quietly and left, but she didn't go away. Instead, she positioned herself at a cleaning cart in the corridor where she could hear the continuing discussion. The doctors' voices carried through the partially open door as they debated more exotic possibilities: chemical contamination, radiation exposure, even discussing whether they should call in the military for a biological warfare assessment. 5:15 a.m. The fourth patient arrived, and Margaret's heart sank. This time, it was an 8-year-old child, Timothy Rodriguez, son of one of the cafeteria workers. Same symptoms, same progression, but seeing a child struggle to breathe broke something inside her. Dr. Williams was now in full panic mode. "Call the CDC now," she shouted to the nurse station. "This is definitely an outbreak. Get me Dr. Fauci's office on the line. We need the infectious disease rapid response team here within hours." The emergency room erupted into controlled chaos. Nurses in full PPE, doctors shouting orders, parents being held back by security as their children were isolated. The sound of heart monitors, ventilators, and urgent conversations filled the air. When Margaret saw the child, her heart ached. She couldn't stay silent anymore. She had taken an oath as a nurse, and that oath didn't expire when you changed uniforms. She approached Dr. Williams, who was frantically reviewing protocol manuals. "Doctor, I can save that child." Dr. Williams turned around, her professional composure finally cracking. "What are you saying? This is a hospital, not a comedy movie. We have people dying of an unknown disease, and you think—" "I've been working here for 50 years, doctor. I was an Army medic in Vietnam before I became a nurse. In 1985, we had the same case. That child will die if—" "Call security," said Dr. Williams, her voice rising. "This woman is violating hospital rules and interfering with medical treatment." But just then, the fifth patient arrived. This time, it was someone Margaret knew personally. Maria Gonzalez, a young woman working in the hospital cafeteria who always greeted Margaret with a warm smile and asked about her day. Maria had been like a daughter to her, one of the few people in the hospital who still treated her with the respect she had once commanded. Margaret went to Maria's side, ignoring the protests from the medical staff. Maria was conscious but struggling to breathe, her face flushed with fever. "Maria, mija, where have you been the last few days? What have you been doing differently?" Maria, with great difficulty, whispered, "Basement, new, renovation, helping with supplies." Margaret's eyes lit up like someone had just turned on a light in a dark room. That was it. The basement renovation. The construction worker, the nurse who had been covering extra shifts and using the basement route between buildings, the administrative assistant who worked late and used the basement parking, Maria, who had been helping move supplies. They had all been in the basement where renovation work was happening. She immediately ran to Dr. Williams, her years of military training evident in her sudden commanding presence. "Doctor, basement floor, renovation work. What are you saying? Where is security? Why is she still here?" "Listen to me," said Margaret, raising her voice with an authority that surprised everyone in the room. Same situation in 1985. Hospital basement was being renovated. Old asbestos pipes had broken. Patients weren't getting sick from asbestos, but from bacteria inside the pipes. Dr. Williams stopped mid-sentence. Something in Margaret's tone made her pause. "What bacteria?" "Legionella pneumophila. It lives in water systems. When old pipes break, it spreads to the water system through aerosols. Chest x-rays appear normal in the first 48 hours because the infection hasn't progressed enough to show infiltrates. Blood tests come out normal because it's an intracellular pathogen, but patients die from respiratory failure if untreated. Everyone in the emergency room fell silent. Even the ambient noise seemed to fade as Margaret's words hung in the air. "Impossible," said Dr. Williams, but her voice had lost its certainty. "We tested for Legionella. It was negative." "For which strain?" asked Margaret, her nursing knowledge kicking in. "There are over 50 types of Legionella. You only tested for the most common, Pneumophila serotype 1, right? That's what the standard hospital protocol calls for." Dr. Williams' face went pale. It was true. The standard Legionella test only covered the most common varieties. In the 1985 case, it was serotype 6. Very rare. Very aggressive. And it thrives in old building water systems. And the water system from that time is still the same infrastructure. If old pipes broke in the basement during renovation work, and workers disturbed standing water that had been stagnant for months, Dr. Anderson came rushing out of the conference room, having heard the raised voices. "What's happening here? Why has this meeting been disrupted?" Margaret turned to him, standing straighter, and for a moment her military bearing was evident, despite the cleaning uniform. "Dr. Anderson, do you remember the 1985 outbreak, from when Dr. Morrison was chief of staff?" Dr. Anderson's expression changed completely, as if a long dormant memory had suddenly surfaced. He looked at Margaret more carefully, studying her face. Are you the nurse from that time? Margaret Chen?" "Yes, doctor." "But you're a cleaning lady now." "I was going to retire, but continued working for economic reasons after my husband passed. I work in housekeeping, but I'm still Margaret Chen. I'm still a nurse." Dr. Anderson turned to the other doctors, his voice carrying new respect. "This woman is the nurse who discovered the 1985 Legionella outbreak. Without her pattern recognition and persistence, 30 people would have died. She convinced Dr. Morrison to test for unusual strains when everyone else was looking for viral causes." The atmosphere in the emergency room suddenly changed. Dr. Williams visibly ashamed of her earlier dismissal. Nurse Chen, what do you recommend?" "Go down to the basement immediately. Find out which pipes were broken during renovation work. Check for standing water, especially in areas that have been closed off. Test the water system, but specifically for Legionella serotype 6. And most importantly, start all patients on azithromycin and levofloxacin combination therapy. Don't wait for test results. They'll recover within 48 hours if I'm right." Dr. Williams immediately gathered her team. The group that had been discussing pandemic protocols and bioterror attacks now rushed down to the basement with flashlights and sample collection kits. What they found confirmed Margaret's diagnosis: broken water pipes in the renovation area, standing pools of stagnant water, and perfect conditions for Legionella growth. Water samples were taken and rushed to the laboratory. Dr. Rodriguez personally oversaw the testing, running specific assays for the less common Legionella strains. 6 hours later, as dawn broke over the hospital, test results came back. Legionella pneumophila serotype 6. Positive. Margaret's recommended treatment was immediately applied to all patients. Within 48 hours, all patients began to recover dramatically. The 8-year-old Timothy was back to his normal energetic self. Maria was sitting up and joking with the nurses, and the construction worker was asking when he could go back to work. Dr. Williams found Margaret during her next shift, as she was quietly mopping floors in the same corridor where the crisis had unfolded. "Margaret, Nurse Chen, I don't know what to say." "You don't need to say anything, doctor." "No, I do. I disrespected you. We all did. You're a nurse with 50 years of experience, military medical training, and a proven track record of saving lives, and we saw you as an elderly cleaning lady. I understand. I've been fighting that perception for years." Dr. Anderson appeared, still looking shaken by how close they had come to a major crisis. "Margaret, I need to talk to you, privately." In the director's office, surrounded by corporate awards and management certifications, Dr. Anderson made an offer that would change everything. "Margaret, I want to make you a formal proposal. The infection control nurse position is open. It pays 3 times what you're making in housekeeping, comes with full benefits, and recognizes your actual qualifications. Would you like it?" Margaret smiled, the first genuine smile anyone had seen from her in months. "Dr. Anderson, I'm 68 years old, and you have 50 years of experience that no amount of modern medical education can replicate. No one in this hospital can compete with your pattern recognition abilities." "But I'm too old. Technology has changed." "Margaret," said Dr. Anderson, leaning forward, "technology gives us data. You give us meaning. That's the difference between information and wisdom." The following week, Margaret Chen put on her nurse uniform again for the first time in years. The familiar weight of the stethoscope around her neck, the purposeful stride down corridors she had walked for decades, the respect in younger colleagues' voices, it all felt like coming home. Dr. Williams came to apologize personally. "Margaret, I have a lot to learn." "We all do," said Margaret, "but the most important lesson is this. Experience comes with age. Wisdom comes with listening. And sometimes the most valuable expertise comes from the most unexpected places." 6 months later, Margaret was giving speeches at national conferences as Metropolitan Hospital's infection control specialist. Her speeches always had the same title: "The Value of 50 Years of Experience, Technology and Humanity Hand in Hand." She spoke about bridging the gap between old-school medical intuition and modern diagnostic tools, about the importance of listening to all healthcare workers, regardless of their current role, and about how hospitals could better utilize the wisdom of their most experienced staff. What saved the hospital that night wasn't high technology, advanced protocols, or prestigious medical degrees. It was Margaret's 50 years of experience, her military-trained ability to recognize patterns under pressure, and the quiet wisdom that no one wanted to listen to. Sometimes, the most valuable answers come from the most unexpected places. And sometimes, the greatest expertise is hidden in the most ordinary-looking person, wearing the most humble uniform, working the least appreciated shift. In a world increasingly dependent on algorithms and protocols, Margaret Chen reminded everyone that human experience, intuition, and the willingness to listen can still save lives.